Now we're going on to the next infection, which is gonorrhea. Gonorrhea is caused by gram-negative Diplococcus bacterium, Neisseria gonorrhea, and an adult woman is contracted by, again, all these are by sexual contact with an infected male. Bacterium infects what? The columnar epithelium of urethra, very important, and the ducts of acini of Bartholin gland and endocervix. So what's very important over here, that it's affecting the endocervix and it's affecting the urethra. Cervix is the main and first site of infection. So I will be asking you, from where do we take the swab for gonorrhea test, and your answer should be cervix. Vulva vagina less frequently infected due to the lining by stratified squamous epithelium, though vulvovaginitis might occur in childhood, but cervix is the place which is highly infected by gonorrhea. Infected women can transmit gonorrhea to their newborns, very important, and they might have specific ophthalmia neonatorum, gonorrhea conjunctivitis, which is a very serious disease and can cause blindness if it is not adequately, appropriately treated, that too early on, very important. So, very important again, if the patient goes asymptomatic, infection only flares up, to be understood later on when the catastrophe has already happened. So, incubation period is very, very short, 2 to 10 days, and almost 50% people, they are asymptomatic or they have subclinical disease. The woman might complain, sooner than later about a purulent vaginal discharge or burning micturition or increased frequency. And there's a combination of urethritis, cervicitis that strongly supports gonorrhea diagnosis, as both sides are infected in most gonorrhea patients. The discharge sometimes causes soreness but not pruritus unless there is associated. So basically the discharge in case of a patient with gonorrhea is not very, very itchy or very causing a lot of symptoms. It's just a little purulent discharge and that's about it. Usually no other symptoms. So then how do you diagnose it? So take every patient who comes with vaginal infection seriously. Sometimes gonorrhea patients are not going to have any symptom whatsoever. But of course, this urethritis is a problem. Many times they come up with the problem of urethral infection, itching, burning, micturition and stuff. So you have to be very, very sure of diagnosing gonorrhea. So how do you diagnose it? You can culture this on a Thier-Martin medium. It's a specific test, very important, but you have to culture from endocervix. So I'll mark this again. Culture from endocervix and urethral discharge is a very specific test of gonorrhea. Apart from that, these NAT tests, which I'm going to be talking about even in chlamydia, are pretty specific. So the newer NAT tests can also detect the gonococcus both from vagina and from the urine. Apart from the diagnosis of gonorrhea, what's very important are what complications can it form. Gonorrhea is very, very notorious for causing PIDs. And then, of course, PID and its sequelae, blocking of the tubes, adhesions, and other problems, and continuous abdominal discomfort, so on and so forth. So, it causes pyosalpinx, it causes salpingo-oophorytis, okay, it causes lower abdominal pain, and it causes dyspareunia, bleeding in between menses. So all these are because it causes PID. Is a very important part of PID. 15% of female who have gonorrhea land up with PID. Apart from that, it can cause, rectal gonorrhea or disseminated gonococcal infection. That's little rare. And then we come to finally, so what is the treatment? Now, the good part of all these diseases is that you finally do have a treatment. Okay, even with treponins, you had a treatment, and pretty easy treatment. Gonorrhea, you have a treatment. Chlamydia, you have a treatment. But viral infections, you remember how notorious they were. Very few of them had real specific, treatments. Most of them were like wait and watch, improve their hydration, give more rest, and stuff like that. So your hands are tied. But in case of patients, these kind of infections like gonorrhea or chlamydia, you have good antibiotics available. For example, let's hear up the gonorrhea treatment. So it's good enough. 1 dose ceftriaxone, 250 milligram intramuscular single dose, sufficient to treat gonorrhea. If the patient is allergic to, there's a penicillin category of drug actually, not exactly penicillin, but of the same family. In that patient, you can give an alternative regime of cefixime, 400 milligrams single dose, along with azithromycin is also being given 1 gram as a single dose. So if you see, those fast kits and all which come, they have azithromycin 1 gram. That's to cover up gonorrhea, but you miss out on seeing this plus sign. So if you do not give ceftriaxone injection, 250 milligram intramuscular, and just give azithromycin, you've tackled half the problem. You have to give one injection of ceftriaxone in that dose to the patient to get cleared of the gonorrhea infection, if at all it is one thing in your differential diagnosis. So remember, when a patient walks into your OPD speaking of abdominal discomfort all the time, always be PID minded and always give this dose once. Okay, so these combo drugs and combo kits that you have available, I'll be taking a class on PID as well. That time I'll be more elaborate to you. But since we're talking already in terms of gonorrhea and gonorrhea infection, it's very vital for you to know that this is the complete treatment for gonorrhea. So you'll be missing out if you just give the kit and not the injection.